Hello, my name is Amresh Hanchate. I am a professor in the Division of Public Health Sciences and the director of the Health Services Research Core, new core within the Wake Forest CTSI. You can find more information about this core and what I'll be talking about today at this website. The main purpose of the core is to facilitate research using encounter or claims data, covering a large number of providers and institutions. This research could take the form of, say, studying ED visits or physician visits, not just within the Wake system, but among all providers and institutions, say, within a county or state or the country. Or it could take the form of merging selected Wake patient data with data from other sources. We may be interested in finding out if our Wake patients also had ED visits, say outside of the Atrium Baptist system. Another purpose of the core is to provide expertise in using these databases in terms of analytic and statistical support, and in designing studies and collaborating on grant-funded studies. Virtually all the data is accessible at no cost to Wake researchers. These are protected data, and we will have to set up access to these data you need on a protected Wake server. And if you also need staff or analyst support to work with these data and analyze and do statistical analysis, the core can provide these services, usually at cost. However, some trainees and early stage researchers may be eligible for these services at no cost. A bit more about the data. We have a wide range of these claims and administrative databases covering Medicare patients, those 65 and older, and commercially insured population, those under 65, and databases covering all payers, including Medicaid, as well as the uninsured. Most of these are very large and include thousands to millions of claims records. Our website provides a detailed list of the databases currently available. What's in the databases? They have records of all the health services received by the covered population. Would include all the hospitalizations, ED visits, physician visits, prescription pickups, and each record would have information about the patient and their health problem, treatment received, usually in terms of codes, ICD or CPT codes, and additional information in terms of cost of care, patient location, maybe the zip code or county, and also information about the hospitals or providers where they received care. A bit about the pros and cons in using such data. On the limitation side, one is that they don't have the amount of clinical detail that you find in EHR. There's no information on vital signs or blood tests or pathology results. And these usually have a significant time lag. Usually they take 1 to 2 years to be available after the encounters happen. On the plus side, the biggest strength is the generalizability of the findings. You can define the study population, not just in terms of convenience, meaning patients who are found in the EHR database, but in terms of the entire population living, say, within a state or the country, regardless of which group of providers they get care from. So not surprisingly, these findings have a lot more significance, and we see such data used in high impact studies across the board in terms of clinical area. And again, if patients receive care in multiple institutions, such data, such events, I should say, are captured, and there's sort of no data holes. And that also makes it more suitable to study disparities, let's say differences in outcomes or utilization of services by race or by payer, because some of these databases include all the payers. We can compare services used by Medicaid patients versus the uninsured patients. One more feature is the linkage. If we have data from one patient cohort in Wake, we could link these data with the claims database for that cohort. And also, since we have location information for the patients, we can link these data with area level information, zip code poverty level, or county availability of providers, and so on. And cost information. Most of these databases include, which is something that is harder to get using EHR databases. And on top of the data resources, the core can provide guidance on the use of these data. We have data analysts who can help with processing these large databases and provide statistical support. And the core faculty can assist in writing grants and working on grant-funded studies. Our faculty are health economists and health services researchers with expertise in studying health policy, cost evaluation, patient outcomes, and disparities. So with that, I will stop. Feel free to get in touch with us if you need more information. Thank you.